Good morning, everyone. Welcome to the McCance Center for Brain Health Seminar Series. Here's information on today's talk. You'll see the SMS code for attendance to claim your CE credit and the required disclosures. And with that, I'm turning over to Dr. Jean Bowman.
Okay, thank you, Elizabeth. Welcome, everybody. My name's Gene Bowman. I'm the director of the clinical trials platform here at the McCance Center and the Brain Nutrition Laboratory. It's my pleasure today to introduce Dr. Gad Marshall. He is currently the director of the clinical trials unit at the Center for Alzheimer's Research and Treatment at the Brigham Women's Hospital, and an associate neurologist at the Brigham Women's Hospital, an assistant neurologist at Mass General Hospital, and professor of neurology here at Harvard Medical School. He received his undergraduate and medical degree from Boston University. He then completed neurology residency at the University of Pittsburgh, followed by a dementia and behavioral neuroscience fellowship at UCLA, and he's board certified in neurology. Over the past 20 years, Dr. Marshall has focused on improving the clinical care of patients with Alzheimer's disease and related conditions in conjunction with clinical research in the field. And over the past 18 years, he's been the site principal investigator of over 15 clinical trials and 5 observational imaging studies in Alzheimer's disease, and is currently serving as the site PI for the ADNI initiative, the Alzheimer's Disease Neuroimaging Initiative. His NIH-funded research is focused on clinical correlates of instrumental activities of daily living and neuropsychiatric symptoms with amyloid, tau, and FDG PET, structural, resting state, functional MRI, and CSF biomarkers across the AD continuum. He's developed novel, sensitive, performance-based instrumental activities of daily living tests for early stage Alzheimer's disease, and this is the topic of his presentation today. Welcome, Dr. Marshall.
Thanks very much, Gene, and thanks everybody for coming. So I'm going to talk about instrumental activities of daily living in preclinical Alzheimer's disease. So let's get going. Here are my disclosures with NIH funding as well as work in clinical trials. So some basic definitions. So basic activities of daily living, which consist of eating, dressing, toileting, grooming, and bathing, are usually manifested in Alzheimer's disease and the moderate to severe stages, and we're not going to focus on that. We're going to focus on instrumental activities of daily living, such as managing the finances, healthcare matters, travel, shopping, preparing meals, and so forth. And those certainly start being evident at mild cognitive impairment and certainly much more in mild dementia. But I'm going to argue that they appear earlier if you ask the question the right way or assess it the right way. And so that's going to be what we're going to review today. So where do they fit, in the early stages of Alzheimer's disease? And again, I think, there's argument there. I think for a while, folks would have said that you have to have dementia to have any degree of decline in instrumental activities of daily living. But, if you stage individuals for Alzheimer's disease clinically with something like a global measure like the clinical dementia rating, when they have MCI, there are plenty of instruments that will show that they have already changes in daily functioning. And that would make sense if you think about pretty complex things such as working or turning in your taxes on time. You can still be independent in many things, but maybe start having some difficulties there if you have some impairment in your cognitive function. And so really one possible explanation for us not seeing changes earlier in IDLs is a lack of sensitive and potentially ecologically valid instruments. And that's what we're going to explore more. So some examples of instruments that have been used over the years to assess IDL. So the most commonly used instruments have been questionnaires, and they would be subjective in the sense that you're asking primarily a patient or a participant, primarily a study partner or a care partner, questions about the individual's daily functioning, although there are some instruments, especially that are trying to detect earlier changes, that will also ask the patient or participant directly. Performance-based instruments are not used as widely. They usually um, try to simulate everyday tasks, or occasionally you're actually observing somebody performing tasks directly and then scoring them. They're considered more objective and potentially ecologically valid, but some of them could be quite burdensome, and so they've not been used as widely. Unobtrusive monitoring is a kind of newer category, not used as widely yet, potentially because of it being newer and the data being quite different. So deploying sensors or having wearables or smartphones to monitor various activities. And you can get continuous data for, hours, days, weeks. So really requires quite different analysis as opposed to a discrete assessment with, one time point where you have potentially one score. So requires a lot more thinking about how to look at that data. Again, considered potentially more ecologically valid, but maybe hard to interpret. And then there are some hybrid assessments that combine subjective IDL and cognitive concerns, and those really are used quite widely. So this slide is a little dated, so more than a decade ago from a review article looking at different instruments, but still gives you a flavor of differences across diagnostic groups. So cognitively normal or unimpaired versus mild cognitive impairment versus AD dementia. And so the functional activities questionnaire, one of the most commonly used instruments and research in studies like ADNI and ADRCs across the country, does well distinguishing between these three different categories. But the score of 0 to 30, you can see that when you're cognitively normal, you're at the floor. You basically have essentially no changes noted on that. The ADCS-ADL, the original version, really targeted dementia, and you're really at ceiling with the cognitively normal folks, and also potentially with MCI. So, and there have been different versions of it, MCI version, and then we'll review some data with the PI version that's really targeting cognitively unimpaired folks. Then the clinical dementia rating that I mentioned earlier, the CDR, which is more of a hybrid tool that combines questions to a study partner as well as the participant. And some of the questions to the participant are also objective in terms of assessing cognitive functioning added together to the questions about daily activities. And so that one certainly, again, differentiates well between these diagnostic groups, but by definition, you're at zero or at floor if you're cognitively unimpaired. And then we go on to the everyday cognition test. And this one does start to show some changes. This one is administered to both participant and study partner as a combination of cognitive concerns as well as daily functioning concerns. And you're not quite at floor anymore with cognitively normal folks. And so you're starting to see some movement there. The last instruments on the list are performance-based assessments. The TFLS is really targeting dementia, and so that one, is an older instrument that was a little bit cumbersome in terms of having to score individuals based on observing them doing various daily activities. The UPSA is a newer version of this instrument, and certainly does show changes in MCI and potentially even a little bit in cognitively unimpaired folks. It's a bit on the long end, though, 30 minutes to complete. And then the financial capacity instrument, the original version, was really targeting MCI and dementia, but there's a short form of it that focused on the more challenging assessments and does show a signal in preclinical or cognitively normal individuals. So this is, again, to give you an overview of what was out there a while ago. And so Next, I'm just going to give a couple examples of an instrument that is sensitive, that's a questionnaire that we looked at. So the ADCS ADLPI, so this is the version of the ADL instrument that I mentioned that original was not actually sensitive for MCI or dementia or normal individuals, but this version honed in on tasks that are more challenging, and when administered to participant and study partner, we can start seeing some changes that can relate to biomarkers. And so this is using data from the clinical trial, the A4 prevention trial, that unfortunately did not show benefit with treatment with solanezumab for individuals who were cognitively unimpaired with elevated amyloid in their brain. However, this became a treasure trove of data as originally designed by Risa Sperling and Paul Azen to at least provide data, even if the actual clinical trial is negative. And trying to screen individuals to determine amyloid positivity for this trial, nearly 4,500 participants underwent amyloid PET. And so with that very large sample, looking at the 15 items of the ADCS ADLPI, we saw that four of the items were endorsed the most as having some changes, some difficulties in performing them, in the range of, about close to 10% of participants noted, some change on those, on one of those. And so when looking at the total score as well as these four select items, we were able to actually show that there was an association with greater amyloid in the brain for both participants and study partners, as noted in the graphs here, for an example of one of the four items, remembering appointments. I mean, the association was weak, and obviously we're highly powered with 4,500 participants, but there was an association cross-sectionally. And so that was a little encouraging that you can see it with a very basic questionnaire. Um, then we followed up on this analysis by focusing on tau PET that was available in about 10% of the sample. So now we're down to 450 because only people who are randomized into the trial or a companion observational arm underwent tau PET, and not everybody did. And so we have about 450 participants who then underwent tau PET, and we have the comparison to the IDL assessment. Again, looking at these four different measures as well as overall score on the test. We did not see as much changes in the overall score, but we were able to see changes on individual items. And in fact, on the next slide, I have examples of the different items where we saw relationships with tau PET. Again, here still a large sample of almost 450 participants. Where cross-sectionally you can see these associations with an instrument that again is pretty basic, 15 items 15 questions that you can ask participants and study partners. And then we looked at this longitudinally, and this work, the last analysis as well as this one is done by my postdoc, Mark Doubleman. So now we have about 4.5 years of follow-up on these individuals, and 1,700 participants across A4 and Learn with amyloid PET, as well as a little over 400 participants with tau PET data. We saw that over that time frame, there was a marginal decline in IDL, and these, again, cognitively unimpaired to start with participants. And that was reported by participants and study partners. And individuals who had elevated amyloid to start with, we saw the highest level, and those were the highest levels of tau, and lateral temporal and medial temporal regions had the largest decline in IDL. And so here are graphics showing us that. the learn group is amyloid negative, and so they're the ones who move the least. And then we have three different gradations for the folks who are in A4 in terms of degree of amyloid in their brain and or tau in their brain. And basically, you can see that the more amyloid and tau you have in your brain over the 4.5 year period, you can note a decline in their daily functioning. There was follow-up even beyond that time frame, but the sample that was an open label extension kind of gradually dwindled. So again, I mean, with a large sample, we can see changes in daily functioning with a very basic questionnaire. So that's just an example of what we can see with current instruments. But I think it would be nicer to see a signal with a smaller sample. I mean, we can't always have the luxury of having such large samples to explore changes in daily functioning, and it would be nicer to have bigger signals as well. And um, what do we need to do to develop a new instrument for daily functioning for early changes in daily functioning? And so we want potentially a proxy for real life function. It doesn't have to be something uh, that's better than cognitive testing, but it may be more clinically meaningful if it's a proxy of real life function. And so that's really I've been focusing on. Again, not to necessarily replace cognitive assessments, but um, especially for clinical trials and then in clinical use of drugs, it's important for the participants and then patients and their study partners or care partners to to note that there is a change for the better in their daily routine, not just necessarily that they score better on a test. And so these recommendations are from Dan Marsden in terms of how can we develop an effective IDL measure for preclinical AD or individuals who are cognitively unimpaired who have evidence of AD biologically. And so we want to assess complex functional abilities that are relevant to independent living. We want to use interval scale direct performance measures that evaluate performance are variable and highly detailed and granular matter. We want time to be a component because many times we hear, in the clinic that patients can still complete certain tasks, but it takes longer to complete them. And so that could be the beginning of a change in their daily functioning. So those are Dan's recommendations from a few years back. And so with that in mind, a while ago now, we developed a phone task, the Harvard Automated Phone Task, as a performance-based assessment to try and capture these type of qualities. And so we started off with two tasks that are basically using an IVRS or phone menu. One of them was a prescription refill, which can still happen quite often if you try to go to your local pharmacy or ahead of time. You call in to refill a prescription, you have to navigate a phone menu. The other one is calling the health insurance company to select a new primary care physician, which sadly, calling your health insurance company often will land you on a phone menu. And so, again, still pretty ecologically valid nowadays. So with these two tasks, um, I'm gonna give you the schema for the first one, and hopefully be able to play the track for the introductory comments. So let's try that now.
You have reached the pharmacy. For prescription refills, press 1. Doctors, press 2.
So that's the introduction there, and then just as another example, you have to enter your date of birth on the phone menu.
Please confirm your date of birth by entering it in the following fashion: 2-digit month, followed by 2-digit day, followed by 4-digit year.
So this one is a pretty simple task. I mean, you're basically calling the pharmacy. You're given a pill bottle as a mock-up pill bottle with a phone number on it and your prescription number ID, and you call the pharmacy. You enter that information, and you ask for a refill. In the evening or the morning. So this is pretty straightforward. The next task is this health insurance task to get a new PCP, and is more complex. And I'll play the intro.
You have reached a health insurance company. Please enter your member ID number followed by the pound sign key. Only enter the number. If the number is preceded by letters, do not enter the letters.
And then you end up in a after you enter your so we give people a mock-up of a card, of insurance card, an insurance card, and then they call the number, they enter their ID, they enter their date of birth, and then you have this like pretty lengthy menu of options, and I have a recording of some of the options here.
Please select one of the following options. To verify members on your policy, please press 1. To change your mailing address, please press 2. To order a member ID card, please press 3. For difficulties obtaining a referral approval by your primary care physician, please press 4.
Yeah, and then it goes on with more options, and then you basically have to pick the option to select a new primary care physician, and then it becomes more complex because you have to actually type in on the phone. So you have a phone that has numbers, but also letters per number. You have to enter the name of the primary care physician and the city that they're in. And so that adds a little bit more complexity to the task. So with these two tasks, over a few years, we piloted this in over 200 individuals. The bulk of them were cognitively unimpaired older adults. You can see we also had some young adults to start with, and then we had a small number of MCI as well as the kind of bookend. We tried a couple, maybe three participants with dementia, mild dementia, and it was way too hard for them. But the MCIs were our bookend for that reason. And then we did some standard cognitive testing, and we also did some subjective IDL assessments on them. The tasks are scored, for total time, as well number of errors and repetition and correct completion. The primary outcome initially for us was a total time adjusted for correct completion, and then over the years we refined that score. But basically, with that, here's the characteristics of this piloting sample. What I'd like you to note is that on the right we have correlations only in cognitively unimpaired older adults, which again is our target group that we're interested in. And you can see that with age, you do worse on these tasks. With higher education or premorbid intelligence, as measured by the MNARD IQ, you do better. And then you do worse if your MMSE is lower on the second task, but not the first task, the simpler task. And then for both tasks, measures of processing speed, TRAILS A, and executive function, TRAILS B, relate to performance as well. And so here's just the output for each of the tasks. And you can see that for our, again, target population, the first task takes a little bit more than a minute. The second task takes about 3.5 minutes to complete. You can see that on the first task, almost everybody, including the MCIs, completed correctly. But for the second task, you can see that the cognitively normal have some difficulties completing correctly, and the MCIs, I mean, a third of them don't complete it correctly and make more errors. And so the second task is really more complex, and we can see that even in the cognitively normal folks. And both tasks don't take that long to complete. And here's just differentiation between diagnostic groups with the tasks, so you can see separation across the groups with the simpler prescription refill, but then it becomes a much nicer separation with the complex task, the health insurance task. And then we did also some test-retest reliability, showing, in a small group of the participants showing reasonable test-retest reliability and stability. Then we decided to look a little bit more closely with cognitive function and running some models adjusted for age and race and education and premorbid intelligence, and saw that for the simpler prescription refill task, there was a stronger association with processing speed test, TRAILS A, and for the more complex health insurance task, we saw a stronger association with TRAILS B, that is more of an executive function test. And these associations were retained after we adjusted for hearing acuity, motor speed, and self-reported difficulties when performing the tasks. Then we went on and compared these to other assessments of daily functioning, and initially with subjective assessments, so the ADCS, ADL-PI, which I showed you earlier with the A4 data. And so with that smaller sample here, you can see a little under 40 of the participants had that assessment. And interestingly, we saw a little split where the folks who had MCI performed better on the prescription refill. That performance, better performance on prescription refill was associated with better study partner reported IDL. So, as the MCIs may not be aware of their deficits necessarily, whereas in the normals, there was better performance in the complex health insurance task associated with participant-reported IDL. So there was a little bit of a split here based on potential awareness of symptoms. Then we had a kind of homegrown IDL assessment that was a data-driven combination of three different IDL assessments that we worked on, and with this particular assessment, there was an association with the complex health insurance task and daily functioning as assessed by subjectively by both the participant and study partner. Then we also used another objective performance-based assessment developed by Sarah Kaya at the time at the University of Miami, and abbreviated here as the CFAB, with two different tasks. One actually the same as ours, but this is performed on a tablet. So a prescription refill, very similar to what we had. And then arguably one of the most ecologically valid assessments, an ATM task, which most ATMs have a touchscreen interface that looks like a tablet nowadays. And so basically doing a couple tasks related to using an ATM on a tablet, and the scoring, again, based on time to completion and correct responses and errors. So we had 46 participants undergo both our task and the CFAB, and we saw associations across the different tasks, which were pretty strong, even though the sample is small. To end this section, we also had a little bit of longitudinal data with these participants followed up to 4 years with a number of repeated phone task performances and two time points for cognitive function. And we basically saw associations between worse performance on our daily functioning task and cognition over time with all the assessments that we looked at. Here are just a couple examples looking at the MMSC longitudinally. And so on the top left corner here, quadrant, we see that if you have worse performance over time on the phone prescription task, you also do worse on the MMSC. And then on the bottom right quadrant, you see that if you have a stable performance on the prescription refill, that's normal. You also have stable high performance on the MMSC over time. And this example is looking at the health insurance task. This is flipped because lower scores on Trails B, the executive function, are better. And so if you have good performance on in the left upper quadrant on the health insurance task over time, you remain with limited change on Trails B performing well over time. And then the bottom right, you have an association with worse performance over time on the phone task and worse performance on Trails B executive function. So to summarize this initial piloting, basically we saw that the phone task, which we think is ecologically valid novel assessment, is in fact has the potential to target changes in preclinical ID in individuals who are cognitively, and because we saw signal individuals who are cognitively normal, we demonstrated differential performance across diagnostic groups, cross-sectionally associated with processing speed and executive function, as well as broader measures of IDL, and another performance-based assessment of IDL. And we also saw good test-retest reliability, and we saw that they tracked well with cognition over time in a small sample. Basically, we thought this was, a good indicator that this could be a good tool for preclinical ID. We weren't fully satisfied. We wanted to add an even more challenging test, so we developed a financial task, and I'll show you that next. And we stayed within the same platform of the phone task. Arguably, this is probably not done anymore with a phone menu, so maybe not as ecologically valid. But of course, we had this particular platform of the phone menu, and so we in this particular task ask individuals to shift money from one account from a savings account into a checkings account in order to be able to pay their taxes for the year. And this has many moving pieces, as you can see in the schema here. And let me play the intro.
You have reached the bank. Please enter your checking account number followed by the pound sign key.
And we give the individuals a statement, a bank statement with their the amount of money they have in their checking account and their savings account, and the different numbers for these accounts. And then the main menu is quite complex, and in fact, the recording for that was done differently, so it's pretty loud. So I'm just going to warn you. Here it comes.
Please select one of the following options to open a new account. Please press 1. To pay a bill or make a payment, please press 2. To make a transfer, please press 3. To order checks, please press 4.
Okay, so maybe not that loud, but louder. So now basically with this complex task, you have to kind of go back and forth on the menu, make the transfer, then go back to the main menu, and then say how much money you want, and then say what you want to make this out to, and how much money you're going to put in. And I mean, you have to do a little bit of calculations, but you can estimate the calculation. We also allow them to write things down, but ultimately, this is a pretty complex task. And we piloted it in different versions and made it simpler and simpler, and it was still pretty complex. This is the final iteration, and we had that on over 60 participants. Took about 5 minutes to complete. Differentiated well between the different diagnostic groups, related more strongly to the more complex health insurance task than the simpler prescription refill. And it was associated with education as well. And so we thought that with the three different tasks, we kind of have this gradation of challenging tasks. So that could help us potentially, if individuals decline over time, they could probably still perform the simplest task, but they may not be able to perform the tougher tasks. But then we have the options. So then we got more funding to look at the phone tasks together with amyloid and tau PET imaging. And so this particular analysis by Chris Gonzalez focused on cross-sectional data initially, and then we had additional longitudinal data with Mark Doubleman, again, the postdoc. And basically, we saw that there were significant associations between the different phone tasks and um, uh, tau PET as well as amyloid PET or interactions between them cross-sectionally, and then longitudinally, we saw that we could predict worse performance on the phone task with amyloid and medial temporal tau. And then also we saw for the simpler tasks, the prescription refill, when there was an interaction with amyloid and tau, that could predict worse performance over time. And then we tried to localize a little bit further with whole brain analysis, the tau signal, showing us, the pretty typical changes in the temporal and medial parietal as well as frontal regions that are not necessarily specific for daily functioning, but rather kind of early AD changes. So, with that in mind, we decided to venture to more digital land and come up with a smartphone-based assessment for daily functioning that would target, again, individuals who are cognitively unimpaired, who may be at risk for Alzheimer's disease. And so we developed the assessment of smartphone everyday tasks, or asset. And this particular task has a few pre-tasks, so a calculator task that's just to assess motor speed and visual acuity and tactile acuity. And then from questions about familiarity with a smartphone that are subjective, but then also objective. So some pre-tasks where you're supposed to change phone settings. Now, arguably, for some folks, this may be novel. They may not do this, and so maybe the pre-tasks with the phone settings are actually testing something novel. But these are not our main interest. The main interest is this patient portal that we simulated, and basically we have different tasks on the patient portal, 4 tasks. Asking individuals to request a refill for a medication that's going to expire, making a payment for a recent visit, and then scheduling an urgent appointment as well as a weekly recurring appointment. And the 2 appointments that are being scheduled, after you schedule them, you have to add them to your calendar. And so, again, arguably, these are things that you can do on your smartphone and are potentially part of the daily routine for individuals. And so with that, we initially piloted asset on a small sample of individuals. You can see here 20 young normals, 17 cognitively older, unimpaired older adults, and then 9 with mild cognitive impairment. And we created 6 different versions and piloted them in-house as well as remotely every 2 weeks. And everybody underwent standard cognitive assessments as well as 2 questionnaires of daily functioning and also a hybrid of daily functioning and subjective cognitive concerns, which is the CFI. So with that, basically, we were able to show that there's good internal consistency between the 2 main tasks, the patient portal and the calendar task, and that the patient portal related to global cognition and study partner, but not self-reported changes in daily functioning. And there was good retest reliability, and most participants rated asset as something that they can use reasonably well. And we have the repeated assessments that were done remotely over time. You can see reasonable stability over time. And of course, worse performance for the older adults compared to the young individuals. And so, again, this was a pretty small pilot, and the initial results of asset, showed that we can distinguish between these diagnostic groups, had good internal consistency and construct validity, and good retest reliability, and it could be self-completed remotely. And so the future directions, which are ongoing and have been ongoing for a while now, after a delay, and we had to switch our partner company that developed the assessment was we had a small business grant together with them, and they were bought out by a big company, so they're no longer a small business. So we ended up switching to another partner, and then resumed our objective, which was to validate this in a multi-center study, which is underway, as well as with AD biomarkers by adding it to our imaging cohorts, and that's also underway. So I think that is my last slide. I'm going to end by thanking all my collaborators, especially postdoc Mark Doubleman, who's done a lot of the work that I showed today, and then really the participants and study partners who answered so many questions, who completed a lot of tasks on the phone and digital assessments, put up with a lot of different procedures. We can't get any information without them. So on that end, on that note, I will end, and then we should have plenty of time for questions, it looks like.
Thank you, Dr. Marshall. If there's anybody that has questions, you can post them in the chat or please raise your hand. Maybe I'll start us off. Thank you for the presentation. Super interesting. I'm wondering, much like the immunotherapies that are able to remove amyloid in the current day, are IADLs something that can be improved over time with treatment, you think? And some of the metrics that you're developing, do you see enhancement or improvement in those over time, or is that a promising strategy?
So improvement is a challenging thing to see when you're trying to use a disease modifying drug. I mean, it's unclear that we should or will see something like that. I mean, so certainly the group comparisons and the trials that were successful for folks who have MCI or mild dementia with lecanemab and donanemab showed a slowing of decline across all their clinical measures, including the measures of daily functioning. And there are all sorts of post hoc small subset analyses that showed potential improvement, not just slowing of decline. I don't really know what to make of those. But if you have an agent that's symptomatic, let's say like the older drugs that we have, cholinesterase inhibitors and memantine, the trials that were done, to lead to approval for those. Certainly all had to look at daily functioning. They were focused on mild to moderate or sometimes severe dementia, where there was a requirement of both cognition and daily functioning to hit on the outcomes, and they showed improvement there. Of course, for those, they had subjective assessments that, were given to study partners, which could be pretty brief, and you could see something there. So I'm not sure with the instruments we're developing here that I reviewed are really targeting individuals who are quite early on in the process. And I guess the question is, will we have symptomatic treatments for asymptomatic individuals, right? In a sense, I mean, do we improve anything there? Or, I mean, so I'm not sure. So, I mean, the goal that I've had is to show that over time you could see a change with these instruments. And that way, if there is decline over time, we will be able to show that with treatment, there will be less decline. I mean, that's the goal. Sorry for the lengthy answer.
No, I'm just thinking from a practical standpoint, somebody's unable to manage their finances, then all of a sudden they've seen Dr. Marshall, and all of a sudden I can manage my finances.
Oh, I wish I had treatments that would do that,
right? Which would be really impactful, right?
Yeah, absolutely.
Any other questions from the group?
Yeah, great talk, Dad. That was really fantastic to get this update and see. I mean, there's so much progress, and it seems revolutionary what you're doing here, and we'd love to incorporate that in what we're doing. I'm just wondering, and you may not have seen it, but there was a paper in Nature Medicine this past week from Oscar Hansen's group on a new digital, self-administered digital cognitive test called BioCog that they're saying is 90% accurate when you compare it to plasma biomarkers like p-tau 217. I'm wondering if you happen to be familiar with it, and what your thoughts might be about it.
Oh, thanks, Rudy. And I have not seen that paper, and I wonder if it's similar to the paper they had probably about a year or two ago. That I mean, I know they have a digital cognitive assessment that they've looked at with plasma biomarkers in that cohort. So I guess, I mean, I'm not sure if it's the same one and now it's a follow-up paper or not. Um, I mean,
Might be.
generally, I would. Yeah, yeah. So, I mean, I think that approach generally is I think a great approach, and a lot of folks are working on it. Their group has certainly been one of the leaders. Locally here, we have Kate Papp and Rebecca Murillo developed Branch, which is also a digital cognitive assessment using a smartphone. I think that these type of assessments, and hopefully asset in the future. I mean, these type of assessments uh, are really important in terms of tracking early changes, clinical changes. Be it cognition, daily functioning, hopefully neuropsychiatric symptoms. These are kind of the hallmarks of clinical changes that we see in neurodegenerative diseases. If you can track those changes very early, and you can track them remotely, and ideally also, including unobtrusive measures, it makes it much more accessible, and you can really do this in a much larger scale, I think. Now, will that be sufficient to replace biomarkers? I don't know that it has to be. I think it has to be combined with
Combined, yeah.
biomarkers. And the plasma biomarkers are really going to make, biomarkers more accessible, right? I mean, so it's starting. I mean, I mean, there are some assays that are being used clinically. And so I think the key would be to combine that type of data because, I mean, you really need clinical measures to tell you what the person is doing clinically, but we know that biologically there could be changes that are much earlier, and so I think that if we know who's at risk, who has what we'd call preclinical AD based on a biomarker, and we want to assess their trajectory clinically, then again, I think the combination of plasma biomarkers and digital assessments that can be done self-completed remotely is
Yeah.
really the wave of the future.
How's the FDA looking at these things? Like the idea of a self-administered digital test. I don't know whether it's this new BioCog or this stuff you talked about, or the CanTab or the Toolbox. I mean,
Yep.
is the
Yep.
FDA coming around to thinking about accepting this for cognitive assessments and trials now?
So I've not seen this approach as being used as a primary outcome in any trials.
Right.
We're starting to see them as secondary. We've seen them as exploratory outcomes for a while now, but we're starting to see them as secondary outcomes. And so I think the FDA is probably coming around to it, but yeah, I mean, I think we're not there yet, unfortunately, but yeah, I think we will get there. I mean, I think that there is enough data to support that these assessments are probably equivalent and sometimes superior to our paper and pencil assessments.
Yeah. I mean, it's one thing to say they measure well against others for diagnosis of the disease and validation against biomarkers. Um, but whether they can be used to assess progress of the effect of a drug or other treatment in a trial is another thing. And um, I guess the question is, how far away are we from making it simpler to do these trials and having a at-home digital assessment that would be as good as the CDR, some of the boxes, or better, that's administered by a rater. I mean, we get it.
Right.
If you had to make a prediction if we're going to get there and when we're going to get there, what might it be?
Right. So I think that we're gathering more and more longitudinal data with these measures that can show you a signal over time, which I think is what we really need. We need that together with, what we've had with cross-sectional data and biomarker associations. Um, and we're in the next few years, we'll have a number of these type of assessments that have enough longitudinal data that you could incorporate them in a fashion like that. I'll just say that, I mean, with the subjective assessments, like the ADCS, ADLPI, and I didn't get into the CFI, the cognitive function index. Um, that those assessments track as well as like the paper and pencil tests, but they take like 2 or 3 minutes to complete, and they're just questionnaires that could be done obviously remotely as well. And so, I mean, their signal, I mean, is good for very large samples. I mean, they may not be as sensitive for smaller samples, but for clinical trials, I mean, I think they're equivalent to what we have, the paper and pencil testing and the CDR. And so it's really, I mean, we should be using those as primary outcomes now, and then hopefully in the future we could use digital outcomes that are more sensitive, and we can, have smaller samples, see what their potential is for individuals, because that's a whole nother issue. I mean, are they useful for determining an outcome for an individual as opposed to group comparisons?
Right. Yeah, benchmarking like the automated phone task against p-tau 17 and other biomarkers in a large study. That'd be great. Fascinating.
Okay, any other question? I see, Elizabeth, do you want to pose your question in the chat around patient-reported experience?
Sure. I was curious how your measures may or may not have a relationship with patient-reported experience. So I'm sure clinically you hear patients say, I feel better, or I just don't feel as sharp as I used to. But are there any kind of actual associations between these measures and patient-reported measures such as PROMs?
Yeah, I mean, so we don't have any kind of classic patient-reported measures in these cohorts where we have been validating these. I mean, we have what we've looked at was more usability questionnaires to see if they feel like these reflect their daily routine, and if they can, if they think that the test is appropriate, and they can tolerate, and things like that. We've also had uh, we have those questionnaires that we have that are not, again, classic patient-reported assessments, but are in fact asking, about performance and daily functioning and cognition of participants and study partners. I mean, so again, related, but not necessarily the classic versions of that, and they certainly relate to that. I mean, I've showed some of that data. So. So we have something similar, not quite what you're asking for, but yeah, on I guess in that range. Yeah.
Okay, looks like we have Alex Rodriguez.
Yeah, I had a quick question. Great talk, Dr. Marshall. My question was, so these phone tests are administered for 30 days, I think you said,
Oh, no,
or
no, not no. These are like discrete assessments. These I'm not sure
oh, sorry,
when I.
sorry, I might have misremembered.
Oh,
My
maybe I was talking about the unobtrusive monitoring that you could do for a prolonged time. Maybe that,
right.
which is not this, but yeah.
Oh, yes, I was gonna ask. So, is this phone call made once and then you assess from there?
Yeah, yeah. So I mean, so this is in that sense, I mean, more similar to the questionnaires or neuropsychological testing, where you kind of have a discrete time point, which is good or bad, right? I mean, it depends on,
Right, right.
it's just a snapshot in time. And I mean, we basically then, it goes to a server, and we get an output of, their performance on time, errors, correct responses, and so forth. But yeah, no, these are just a snapshot of,
Snapshot.
yeah,
And
yeah.
is there a platform to repeat these measurements down the road, so you can get a longitudinal perspective?
Yeah, yeah. So we are doing that, and I briefly reviewed some of the longitudinal data and the imaging cohort. We Yeah, so we've been doing that with annual assessments. Uh, some folks we've had up to 6 years
Mhm.
of follow-up on them, the cognitively unimpaired folks. And we've had 3-year follow-up on a larger sample of cognitively unimpaired and subjective cognitive decline folks, and so we have been looking at that. Yeah.
Okay, great. Thank you.
Yep.
So I know we've talked,
Can I,
about the, yeah, go ahead, Hiroko.
oh yeah, can I
Your
ask
question?
one question? The time is coming up, so I'll be quick. Um, among all these assessments, which one can be done multiple times? It's related to Alex questions, which one can be frequently assessed? I ask this because if we, can assess frequently, we can always calculate the individual, within individual changes in a clinical trial, which can be more powerful than group level. So I'm
Right.
wondering which one is suited for this individual changes.
Yeah, yeah. Thank you, Hiroko. It's good to see you. Um, so that's similar to what they're doing in Branch, what you're asking, the digital cognitive assessment, where they're doing daily assessments for 7 days, and then they extract us something equivalent to a slope from that to see a trajectory in that short period of time, which is more sensitive to changes than just a single time point. So I mean I would say that we could do that with probably either of these. We haven't tried it. We've talked about doing it for a while. We haven't tried it yet. And I mean we have what we've done with the asset is like every 2 weeks we've done that for part of our validation with but it was with different versions. What you're talking about, I think, would be probably similar to what they do with Branch, which is the same version every day. And I mean, I think that we could do that, and then see what it looks like. I mean, that may be more reliable, as you said. Asset takes about 15 minutes to complete, so
Mhm,
not that long.
mhm.
Yeah.
Oh, yeah, thank you so much. Very interesting. Got
Yeah, and
nice
I
presentation. Thank you.
just to follow up to that, the nature of some of these cognitive measures, you do see a learning effect, at least initially on repeat testing.
Yeah.
Is the nature of the longitudinal change similar, you think, in some of these other instruments for activities of daily living where there is a learning effect initially, and then you can kind of have a true longitudinal characterization of that individual based on the metric over time?
Yeah, I mean, I guess, I mean, we haven't seen it in a sample that we have so far with the phone task. We haven't seen that learning effect. I mean, um, so I mean, we'll have to see with as we get even more longitudinal data. But so far we are not seeing that.
Huh.
Um, I mean that. It does behave in a sense like a neuropsychological test in terms of how we score it, and so it has that potential. But I'm not sure we're not actually seeing that in the cognitively unimpaired folks. Where as you're saying, when we do kind of typical paper and pencil tests in those folks, we do see that, and after maybe 4 or 5 years, it tends to wear off, at least in our Harvard Aging Brain Study cohort. So yeah, I mean for whatever reason, we're not seeing that actually.
I wonder if that could mean that it's more suitable to see effects over, a shorter duration, potentially, compared to normal neuropsych.
Right, right. That is possible. And I think, I mean, certainly with Branch, I think they have been able to show that as well in a shorter interval. And so yeah, I mean, which of course would be really nice for these very long prevention trials.
Right, right. Well, extremely interesting. Thank you so much for your time today, Gad, and for coming and being part of the community and sharing your work. I'm sure several of us will be in touch, and we'll see you around. Thank you so much.
No, thank you everybody for listening.
Okay. All right. Take care.
Thanks. Thanks.
Thank you, everybody.